Hi guys, welcome back to BROMED Lectures. In this video, we're going to be addressing hypopituitarism. So in this part of the video, we're going to go through the etiologies and some of the important associations that you need to know for the exam. Hypopituitarism is usually caused due to a direct blow to the gland. And this causes either a metabolic dysfunction or altered irrigation to the gland. So for tumors, we have adenomas in adults being the most common ones, but in children, it's usually due to craniopharyngiomas. And so search for the calcification and hemorrhage seen on biopsy, and remember this association. For Sheehan syndrome, we usually see the patient that has hypovolemic shock during childbirth. And this is due to hypertrophy of the gland during pregnancy due to the prolactin cells outgrowing the gland, and now with this hypovolemic shock state, the patient generates an infarction of the gland. And you're going to recognize because the earliest symptom is going to be cessation of lactation. These patients can develop panhypopituitarism further in time, but you early recognize with cessation of lactation. Replace the prolactin, your kid's going to do fine. Now, apoplexy, this is defined as a sudden onset. Remember this, a sudden onset of headache, nausea, vomiting, and loss of consciousness. And this is due to the lack of cortisol and a lack of a stress response for these patients that develops acutely. And although there's many etiologies for hemorrhage and infarction to develop, this is usually recognized as the sudden onset of this syndrome in a patient that you measure these hormones and they are lacking cortisol, thyroid hormones, etc. In empty cell syndrome, there's an association to primary etiology with obese hypertensive women. And although we don't really know the exact mechanism, it is suggested that it is the subarachnoid tissues that outgrow the position of the gland, leading to atrophy. And for secondary, you have radiation therapy. For any other tumor, it can be the ones mentioned in here, surgery, especially if it is due to one of the tumors in here, or trauma. A direct blow to the gland leads to loss of function. So for this part of the video, we're going to go through the signs and symptoms, the diagnosis, and the treatment for these patients. So the signs and symptoms are pretty straightforward. The lack of the hormone, the symptom. So for the FSH and LH, you're going to see amenorrhea, loss of libido, and erectile dysfunction. For GH, in children, you have growth delay, and in adults, you have hypoglycemia and loss of muscle mass. For TSH, you have the hypothyroidism symptoms. This is the patient that is cold, weak, with dry skin, and with increasing weight. For ACTH, this is the loss of cortisol, but remember that this only develops if the patient has an stress situation. Low prolactin, no lactation, and that's going to be for these hormones. So for the diagnosis, the ones that are more specific are for the GH, in which you preferably do an arginine suppression test, in which the arginine is going to suppress the somatostatin production. That's going to lead to an increase of GH. So if you see that these patients do not develop an increase in GH, you have your diagnosis. For ACTH, we have a similar mechanism of test in which the meteropone inhibits the cortisol, and you want to see in a normal patient the ACTH levels rising up. So if you don't see the ACTH levels rising, you also have your diagnosis of hypopituitarism. For the other hormones, the FSH, LH, reproductive hormones, the thyroid hormones, and the prolactin, you need to perform measurement of these levels. And for the treatment, it's pretty straightforward. Replenish the hormones. Remember that the first one's going to be cortisol. This is going to be your number one responsibility, since this is the one that the patients may develop into symptoms acutely. And so you give these to all patients. Then you have the thyroid hormones, then the reproductive hormones, and lastly, the GH. And that's going to be for the video.